All right, so Parkinson's disease is another form of dementia. All right, so Alzheimer's was the most common. Parkinson's is probably second place, and the cause is really unknown. There are ways to get it, like with pesticides and welding and diet, iron deficiencies and such, or iron toxicity, sorry. But really, to develop it, it's really difficult to kind of identify the exact cause of Parkinson's. Alzheimer's, how much people are higher risk for some reason, right? But it's a progressive neurodegenerative disease. Again, it falls under dementia. Okay, and we're developing these what are called Lewy bodies, and these little bodies are developing specifically in one specific spot. It's not like Alzheimer's can go beyond the hippocampus. Strokes can go anywhere, right? But Parkinson's disease is just the substantia nigra pars compacta. Just one little tiny spot in the brain gets turned offline, right? And dopamine physiology is incredibly complex, right? Whenever I review my slides, I kind of stop here for like 30 minutes to an hour because I just want to try to understand it, and then I usually give up. But I think I spelled it out before, but I simplified it the most. The whole purpose of dopamine is to make fine movements, because you can send an impulse from your brain down to your arm to contract, right? But if you do that, you're going to look like a robot, like contract, right? You're just going to contract. You're going to bring your arm all the way up. But how do you make that a smooth movement, right? How do you do that smoothly? That's dopamine. Dopamine inhibits the positivities of it contracting, and then it can let it relax, right? It can adjust those things. So that's what dopamine is doing. It's increasing wanted movements and decreasing unwanted movements. So it's balancing those things, right? It's making it have smooth movements. The ridiculousness of this is it's like a 7-step pathway that the substantia nigra right here is inhibiting and stimulating, right? You can see how it's inhibiting the inhibition of excitation of the inhibition of the thalamus. It's absolutely ridiculous, right? You're going to get a headache trying to figure it out. But essentially the end result is it's going to promote, it's going to let you do movement, and it's going to let you inhibit movement you don't want, right? Like at rest, how do I make my hand just not start moving, right? If I have a lot of caffeine, which I did, it might tremor, right? But I can stop that, or at rest, if I'm not thinking about it, it can also be inhibited, right? And acetylcholine, by the way, also is going to do the exact opposite. So we do not want acetylcholine around, right? Acetylcholine is going to inhibit our dopamine processes. So what happens in Parkinson's is those little areas of the brain are not functional, so dopamine is going to lose its action. It's going to lose its inhibition of the stimulation of the inhibition of the thalamus. It's like, okay, what the hell does that mean? That means that it's going to, you can no longer do a movement smoothly anymore. So what does it look like? It looks rigid. You have rigidity, right? You have also trouble initiating movements, right? So you're unable to, you wanted to say, hey, I want to go ahead and lift my hand. You have difficulty doing that action because dopamine does both things. It inhibits things, right? It also stimulates things. So you lose that ability, so you cannot start movements. It's called bradykinesia. Kinesia meaning movement, brady meaning slow. So they're slow to move. It can even lead to akinesia, absence of movement. They just kind of stop. And they can't function. They cannot start, right? It's like when you're watching Netflix. You haven't picked something yet. That's called akinesia. All right, and then tremors and rigidity. So at rest, they can't inhibit what they're doing at rest. So they have a resting tremor, right? And then when they want to try to move, it's going to take them a second, but they're going to move, and that tremor is going to go away, right? That's called a resting tremor versus an intention tremor. With multiple sclerosis, they have intention tremors. When they move, they tremor, right? From multiple sclerosis. For Parkinson's, they just at rest, they're tremoring, right? And then on the side, what does dopamine also do? It also makes you happy, you can think of, right? So it works in the limbic system, and therefore you're going to have a lack of dopamine in the limbic system. You're going to have depression as also a side effect of all of this, right? You get psychiatric manifestations, okay? So you have loss, you got anxiety, depression, right? We have our inability to activate, right? So we have these mask-like faces. They can't really move their muscles of their face that well. If they want to express, it takes them a second to respond. And when they do express, they might be very, very quiet because they can barely move their vocal cords and their tongue at least Your vocal cords don't really, your tongue doesn't move as great as it could. They can't form speech that well. When they write things, it's like super, super small. So it looks like what's called micrographia, right? So they're really, really slow. So they're really sluggish to initiate movements, right? They have a trap as a mnemonic, right? So T meaning they have a tremor at rest or with intention. I'm not sure why it's playing sounds, but anyways, you have a resting tremor. Okay? So then you have it will decrease with movement. As they start moving, that tremor goes away, right? And then R is rigidity, so they're rigid, they're cogwheel like a robot there. They try to move things and they are very rigid in their movements. And then A for akinesia. Bradykinesia happens first, where they're really, really slow to move at first. And then P for postural instability. So their posture starts getting very, very unstable. They got a shuffling gait like this. Notice they're very bradykinesia. They're moving very slow. Right, so that puts you at risk for falls, but also dopamine works on our orthostasis as well. So when we give medications that potentiate dopamine, that's going to, or it's a different mechanism actually, but they're high risk for falls right here because their posture is not that great. They can't support their muscles like they normally do. Again, the mood, cognitive, behavioral changes might change. There's no diagnostic test you can do. It's like, oh, look, your lab, it shows Parkinson's. There's nothing to that effect. All right? And you can see here the decline here is when they start getting immobile. That's when they start getting all the complications of immobility. Right? Eventually, they can't get out of bed. And now they are immobile. So the pharmacology for Parkinson's. All right? So Parkinson's, there's no treatment that's going to stop the disease progression. It's just going to help them move throughout life. Literally, helps them move. Okay, the goal is to increase dopamine because Parkinson's is a lack of dopamine, right? So how do we increase dopamine? Well, we can give them the building blocks for dopamine. We can provide them L-dopa and make it, that's going to be the precursor for dopamine. It's like, here, have more dopamine to make more dopamine, right? Or dopamine building blocks, I should say. Right? The other thing is we can, once we do make the dopamine, we can say, hey, don't break it down. Once it's there, don't break it down. We have more dopamine available. So those are enzymes that break down dopamine. So we tell the enzymes we're going to potentiate those enzymes, and then now dopamine is going to be around for longer, right? And the other thing we can do is we can just give synthetic dopamine. That synthetic dopamine is going to bind to these little receptors where they're intended to go, and now you have the synthetic dopamine available to do dopamine's action, right? Those are the major three classes. Then we have another one that helps with tremors, right? So we're going to get rid of acetylcholine because acetylcholine is our enemy in Parkinson's disease. It's not the enemy when we talk about myasthenia. Okay, so the pharmacology, again, we have dopamine, just precursors. We have enzyme inhibitors. We have agonists. And then we have anticholinergics down here. So the next couple of slides are going to be tell us why. These are tell more detail on these, but this is the overview of all of our pharmacology for Parkinson's. So dopamine precursors. So we have the precursor L-dopa. It's the building block for dopamine, and basically just provides dopamine. And the L-dopa, when you give dopamine just via GI tract or something, your body's going to say, oh, I like dopamine, and it's going to use it because dopamine is a precursor for norepinephrine and epinephrine, right? So your body's just going to use that dopamine. So we have to give a combination drug. It's called levodopa-carbidopa. And the carbidopa stops the breakdown of L-dopa, so it can make its way all the way to the brain, and then finally the L-dopa can cross through and be used where it needs to be used, inside the brain instead of peripherally. Right? So carbidopa will stop its breakdown until it gets all the way. It's like a presidential cavalcade, what's it called? Motorcade, right? It's going to get it all the way over there, and then finally it's going to get to its destination. Okay? It needs to be taken on an empty stomach, so it gets absorbed appropriately. So it needs to be on an empty stomach. It also needs to be, they may require more doses as the disease gets more advanced. They have less and less dopamine receptors, so they need, or dopamine neurons, so they need more medication. So orthostatic hypotension, right? So carbidopa inhibits the breakdown of dopamine, but it also inhibits norepinephrine, which is responsible for vasoconstricting, so that when you rise, you have a good blood pressure. So it's a significant side effect of this medication, of carbidopa, levodopa. Nausea and vomiting, because when you give an antiemetic, you're inhibiting dopamine on what's called the chemoreceptor trigger zone. So the CTZ, the chemoreceptor trigger zone, when that gets stimulated, that's going to make you vomit, right? So when you give an antiemetic like metoclopramide, that's going to block that site, and therefore you're going to not vomit. But you blocked dopamine in the brain, and therefore your Parkinson's is going to get worse. So you want to avoid these medications with Parkinson's. And schizophrenia, so too much dopamine is what causes hallucinations and psychosis. So you're providing all the dopamine for hallucinations. And then black body fluids. I can't figure out a reason why it's black, but it causes your body fluids to be black. Or it's cool on Halloween at least. And then on-off syndrome is a significant side effect of this medication. On-off means that they have unpredictable akinesia. They're like walking across the street and they stop in the crosswalk. So what's going on? It's like their dopamine is exhausted. They have no more dopamine to give, right? Have more dopes to give anyways, but they have more dopamine. It's all in exhausted. And why is it exhausted? Because, well, maybe they forgot the medication, right? Or they took the medication, too early, and now it's late in the day, right? So it's important this medication gets taken around the clock and also being taken on an empty stomach. Also, with disease progression, they need more and more of the medications. They might not have the right amount as well. And then sometimes you have way too much dopamine, and the dopamine gets down-regulated. In the brainstem, you have to give these medications right here. They're specifically for on-off symptoms, and you give these guys can be given PO or IV, or PO or sub-Q, or transdermal. Those are medications that are given when someone has a complication of this medication. And this medication has been around for 60, 75 years. That's why it's has a lot of side effects, but it's still our best drug we could give for Parkinson's. The other final side effect is neuroleptic malignant syndrome, and that doesn't sound nice at all. So NMS, or neuroleptic malignant syndrome, is where you have a excess amount of dopamine, and then all of a sudden you withdraw it. And now the brain freaks out and it starts overproducing serotonins and other things, and you get this extreme fever, like 106, 108 Fahrenheit. It's an extremely, extremely high fever. So fever, they're going to get altered because of that. So falter is the mnemonic. Fever, altered, the white count goes up, leukocytosis. They start getting tremors, elevated CPK, their muscles start breaking down. And the only fix for that is dantrolene. That's one of our fixes for NMS. So for this medication, it's for Parkinson's, but it could cause on-off syndrome, and we have to then give medication to fix that. And it could also cause neuroleptic malignant syndrome if you don't give this medication, right? So it's very important when you do the medical reconciliation or medicine reconciliation, when they come to the hospital, it's like, oh, they're fine. We're going to go cold turkey, right? When you go cold turkey, like clonidine and beta blockers, which I didn't ask a question on, right? But anyways, you have beta blockers and clonidine. If you stop those all of a sudden, that's going to cause rebound hypertension. You stop this all of a sudden, it's going to cause your neuroleptic malignant syndrome. Okay. So on-off syndrome is a significant side effect. We have to make sure we're taking the medication around the clock. And sometimes it can just build up to the point where we have to go on a holiday and we give the dopamine agonists. All right, so other dopamine agents. It's all funky. Anyways, we have, like we mentioned, we have the precursor dopamine, or we can have an enzyme that prevents the breakdown of it, right? So we can have the medication around or the dopamine around for longer. So we have these two enzymes we can inhibit, because these enzymes will break down dopamine, so let's inhibit them. That way dopamine stays around longer, right? We have al Capone or entacapone. We have tolcapone, selegiline or rasagiline. These guys are medications that will inhibit the breakdown of dopamine. Specifically, these guys right here, these MAOs, you'll see these again in psych, and they're an old antidepressant, so that's actually a benefit of this medication. It actually cures depression, but specifically they have to avoid tyramine-containing foods. And what the heck is tyramine? Tyramine is found in like aged things, aged wines, aged cheeses, charcuterie boards, right? That's the significant consideration for that one medication. But it's providing more dopamine, so you're still going to get on-off symptoms. You're still going to get NMS if they stop the medication all of a sudden, right? And then we have these three guys right here. These three guys are for on-off syndrome, Right? When they develop on-off, these are the rescue drugs. These are the ones that are going to rescue the patient, and they're going to bind the receptors, the dopamine receptors, but they're not going to build up too much dopamine like the other guys did. Right? And then we have anticholinergics. Anticholinergics are going to, acetylcholine was the enemy of dopamine, so we're going to stop acetylcholine with anticholinergics. And if acetylcholine, like with our Alzheimer's drugs, if acetylcholine was causing us to get really juicy with like sludge BB, this is going to be the opposite. Everything dries up, right? Everything's super, super dry, right? And it's including your tear ducts, right? So your tear ducts get really dry. You can't pee that well. Your bladder needs acetylcholine to pee, right? So you're blocking that. You don't have saliva, and you're probably going to be very constipated because you're not making a lot of GI juices, right? So it's can't see, can't pee, can't spit, can't fill in the blanks, okay? So that's the idea with these guys right here. So we're stopping the breakdown of dopamine itself. Dopamine is being provided, and these enzymes will break it down. So we are going to block those enzymes, right? So that dopamine can stay around for longer. All right, so medication adherence is really important because if they stop the medication, their Parkinson's symptoms are going to return, right? So on-off syndrome, we mentioned that's a specific treatment there. NMS, we give dantrolene and benzos. If they're drooling, you give an anticholinergic, like glycopyrrolate, can help. It specifically works just on the oral cavity and the upper airway, so it's going to dry up secretions. All right, and what else? Hallucinations, antidepressants might be needed because we're giving dopamine that causes like schizophrenic symptoms. And then orthostatic hypotension. So we mentioned that's a significant side effect of Sinemet, which is our combo drug, levodopa, carbidopa. And they're a high fall risk because of their gait, because of the orthostasis from the medications. And if medications don't work, we have a catheter we can put right into the basal ganglia that the substantia nigra is a part of, and we can interrupt that pathway, that 7-layer pathway. We can interrupt that, and we can help fix the the Parkinson's-like symptoms.
This actually blew my mind. In 1982, a 30-year-old woman from Scotland named Joy Milne was walking her husband Les back home from work when she felt something about him was off. There was this intense musty smell to him that hadn't been there before. And although Joy figured it must have been something from work, over the next few weeks and months it only seemed to get stronger. To her frustration, no one else seemed to smell it at all, and eventually it just became something that she had to live with. 12 years later, in 1994, Les was diagnosed with Parkinson's disease. Joy decided to attend a support group with him, but the minute she walked into the room, that exact same smell was radiating from every single person there. Turns out, Joy could somehow smell Parkinson's. And although she immediately went to a researcher with her findings, she was flat out dismissed. That is until she successfully passed the researcher's test of identifying Parkinson's just from people's shirts while blindfolded. She only made a single mistake. But months later, it would turn out the guy she wrongly chose would also be diagnosed. Recently, Joy has worked with researchers to develop a new test that has been able to detect Parkinson's with 95% accuracy. This could actually be huge.